With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone, welcome to the November 2019 edition of PRS Journal Club podcast. I'm Kyle Sanniec, PRS Resident Ambassador from UT Southwestern, and I'm joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis and Lily Mundy from Duke University. Today we have the honor of being joined by Dr. Michael Neumeister, Chairman of the Department of Surgery and Professor of Plastic Surgery at Southern Illinois University School of Medicine. Thank you so much, Dr. Neumeister, for joining us for this PRS Journal Club podcast.
Oh, thanks. This is going to be a lot of fun. It's an honor for me to be here.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The next article we will be discussing is Outcome of Recurrent Surgery in Dupuytren's Disease, Comparison with Initial Treatment by Dr. Sels out of Netherlands. The purpose of this study was to compare differences in treatment effectiveness of initial treatment with repeated surgery in Dupuytren's patients, and to assess if patients undergoing surgery at different levels of contracture rate and hand function for the secondary surgery. The authors looked at all patients who underwent treatment and then repeated treatment for Dupuytren's over a 6-year period. Baseline demographics and complications were also assessed. The treatment was based on shared decision-making with the patients and included collagenase, needle fasciotomy, limited fasciectomy with and without skin grafting. They had certified hand therapists who assessed degree of residual contracture, and the patients reported outcomes via the Michigan Hand Questionnaire. A total of 114 patients were included. The time between operations was roughly 2.2 years, and the majority of initial treatments were needle fasciotomy in 45% of the treatment group and limited fasciectomy in 40%. The most common treatment for recurrent contracture was a limited fasciectomy. There was a 7% complication rate in the initial treatment group and a 14% complication with repeat treatments. They also noted that the different treatment types had similar complication rates. Of the patients who underwent a limited fasciectomy, 83% had a repeat fasciectomy. However, when they looked at patients who underwent needle fasciotomy, 75% of those patients ended up being converted to a limited fasciectomy during the repeat procedure. The contracture reduction in the repeated treatment was significantly better in patients who underwent a needle fasciotomy first compared to those that underwent a limited fasciectomy first. Overall, I thought this was an interesting study with some good information to discuss with patients. Dupuytren's is such a confusing disease at times in that we aren't always sure why some patients will recur rapidly after we do some kind of treatment and others are resolved after one treatment or have a very prolonged remission period after our treatment. I think the study does give us some info that using needle epineuritis doesn't preclude additional treatment in the future, and that repeat treatment actually gets better motion back than doing a repeat of a limited fasciectomy. Additionally, patient-reported outcomes are equivalent between the two main groups, indicating that both will leave patients relatively satisfied. One of the things I wish the authors would have done is a longer follow-up. They state that they had outcomes at 3 months, which is great, but given that there is a worse recurrence on average of 2 years after initial treatment, this doesn't seem like a long enough time. Additionally, they have some patients that underwent collagenase injections, but then this was stopped secondary to financing. So it's hard to say what role collagenase plays in recurrence and in improvement after additional surgical treatment, as the collagenase can often make a secondary surgery more challenging. So I think with that, Dr. Neumeister, I wanted to see, what are your thoughts on this study?
So if you look at actually overall the conclusion of their study said this is used more for preoperative counseling of patients with Dupuytren's, and not specifically to change a practice. And I think I would agree with that, and I think they've actually accomplished that. They had 114 patients, not a bad volume. They have a national registry. And one of the concerns I have about the paper is the enrollment in the registry. You mentioned something about follow-up and time for follow-up, but it's actually limited in a few ways. Of the 114 patients, only 57 had the contraction measurements with the goniometry initially, and only 48 afterwards. And not even that, but not everyone had the Michigan Hand Questionnaire. So 94 out of the 114 initially, and in follow-up only 66. These are issues when it comes to analyzing data that would help us really glean the best out of articles like this, because I think they were unable to do statistics on them because at the end of the day, it ended up with kind of small sample sizes with all the data being there. And I think registries are kind of meant to gather all the information so that we can, extract that and mine as much as we can out of it. The other thing that they did was when they talk about each one of the fingers, if there's multiple digits involved, they took the measurements of the most severely contracted. But it doesn't go further to describe, so if that's the ring finger at the initial treatment, was the second procedure on the same finger? Or did they come back in and say, okay, now my little finger is the most severe? And did they use that one? So I was looking for a little bit of continuity on those digits, which kind of lends itself to one of the last comments about that. Dupuytren's patients, as you know, deal with this for a long time. I got a nodule, I got a cord, depending on, what their profession is. I can't take time off. That's not really bothering me yet. Now it's getting too contracted down. Can you do something about it? If they have a recurrence of that, they are not likely to come back to see you until it is actually more severe than the first time, because they've said, I've lived with it. Oh my God, now I got to go through that procedure again and recuperation. And I'm not going to do it until I know it's at least as bad as what it was before. And that's exactly what they found. When they came back the second time, the contracture was worse. And they had a good release that time. So after the first release, it was good, and after the second release was good. Years ago, Bob McFarland out of London, Ontario, actually described Dupuytren's little finger, the PIP joint, and said if you have a contracture that is significant in that finger, that releasing the volar plate and collateral ligaments is probably not going to gain you too much in the long run, because it'll always contract back, especially on the little finger, and it may actually get worse. The other thing I didn't know from this paper, is it actually a Dupuytren's recurrence or the contracture as a result of volar plate that had been released before? And we don't know any specifics about those type of releases, because even in limited fasciectomies, you may do a release of a volar plate. Or was it something else? So we have to find each one of these points in order to make sure we're discussing this paper the way we should be discussing. Overall, I think they actually had recurrence rates. The mean follow-up was 2 years, yet they still had people coming back for secondary operations. That's pretty early in a Dupuytren's recurrence, indicating that this may be pretty significant disease. So it would have been nice to discuss, do they have a diathesis, or the bilateral hands, has strong family history. Those are things that may also influence the data. Overall, they're correct though. What they were looking for about first surgeries and second surgery, does it make a difference as to what you had first? And it seems to have. I think they actually showed that it might. Doing a needle eponeurotomy, you're more likely to do a more definitive procedure later on, and they're more likely to get a recurrence than if you've done a partial fasciectomy. So I like the paper. These are authors with an extensive experience with Dupuytren's disease. I can tell you that, though.
Thanks for the thoughts, Dr. Neumeister. I was wondering, what is your treatment algorithm for Dupuytren's in general? When a new patient comes in and sees you, are you doing collagenase? Are you doing needle epineuritis, limited fasciectomies? What's your treatment algorithm for that?
So some primary comes in, they haven't had any other treatment before, and they have a contracture. My primary go-to is collagenase, and I will inject that. People are very happy to see the extension, and I see them on a Monday, Thursday, I'll actually extend their finger. They have bruising and some tenderness. They come back 2 weeks later, and they're happy with the overall result with that. I have seen a couple come back now 5 years out with some recurrences. I've injected again, and I've also done limited fasciectomies on those again. Anyone who comes to me with previous operation with scar tissue in there, I'm probably more prone, I'll do the collagenase, but more prone to go back in there and surgically remove the scar tissue and release contractures and recurrent Dupuytren's. I actually have done things like a needle eponeurotomy plus fat grafting. Roger Corey in Miami has sort of spearheaded that effort, and it's worked. It's worked remarkably well on a few folks. They may have had a procedure before, and I was going to do a fasciectomy, and they said, yeah, I've heard that can be uncomfortable, therapy afterwards. And I said, well, let me try something. And it remained soft, pliable, and got their fingers extended.
Yeah, I've heard about using fat grafting at the time of the needle epineuritis. It's a very interesting concept that Corey brings up. I wonder, you mentioned a little bit on recurrence, how do you counsel patients from that first meeting about the recurrence rates and talk to them about the course of their Dupuytren's disease that they're going to have when you're first educating them?
Sure. Very open about that, saying I'm not going to quote you any numbers about recurrence because if it happens to you, it's 100%. But what we know about Dupuytren's is we don't know the natural history in you, in that it may stop right now. And what the disease process that you have right now may be at its end, and it may not get any worse. Or it could continue to contract down. Or you could get it even worse in the other hand. We don't know that part of the natural history. We know there's cycles, and we know it goes through various phases and cellular phases and biochemical phases. But in you, I'm pointing to the patient, in you, I don't know exactly how it's going to react. The other thing I don't know is, will it come back in you? And will it come back fast or slow? So I tell them that there is a chance, and if you want some sort of number, I'd say 1/3 of them may come back in you. And I'm pulling that out of my hat because I don't want to give them a number. It's just so variable. But essentially saying the chances of a recurrence are certainly there, but this will buy you a lot of time with your fingers extended. But like this paper, I tell them you will come back to me actually when it gets to be more severe than what it was the first time, because you lived with it for so long. Natural history, we don't know exactly what's going to happen with that. Once we resect it, we don't know the exact natural history that could occur. But most people seem to enjoy the comfort of either having the collagenase or the resection, at least for a period of time when they can suddenly use their hand to a greater extent.
You know, going back to kind of the collagenase and aponeurotomies, what role do you think cost should play in the treatment algorithm for Dupuytren's? You know, there's a lot of stuff that's been coming out recently on, you know, cost of Dupuytren's treatment with the collagenase and needle aponeurotomy and limited fasciectomy. What role do you think that should play as we go forward with Dupuytren's treatment?
Yeah, I think it's worthwhile actually analyzing that. In this article, they state that it's not covered by their national health system, and in that regard, collagenase is not used as much these days. And I think that's a cost thing that their government has said and healthcare system has said that we're not willing to pay that. It didn't seem to be cost beneficial to them. Individuals, and when you look at some of the work that Kevin Chung has done with quality for your lifespan, it may actually have a benefit knowing that your downtime is less, your productivity during that, what would have been downtime, is far higher, and you're able to enjoy a quality of life that's better for during the period that you're convalescing from surgery or the injection. So in the long run, I think we should be looking at cost effectiveness of each one of the regimens, but I think it has to be individualized depending on the job the patient has, the time in their life that they have available for therapy. Because secondary procedures, scar tissue therapy, time away from work, that all affects not just the overall cost of that one procedure, but there's a cost to the patient, to society, and all of us as a result of downtime.
Thank you, Dr. Neumeister. Lily, I'm interested to hear what you think about the study, specifically the patient-reported outcomes and what you thought about that as it related to the study.
I know that the Michigan Hand Questionnaire has some of its limitations, but it's really the most widely used patient-reported outcome instrument in hand surgery at this time. You know, I thought it was nice that they provided those outcomes. It's a little hard to tell how significant some of these changes are, and when they broke it into the different subscales, which of these were clinically sort of relevant changes, like in work function or pain scores, ADLs, you know, general hand function, things like that. Obviously, it looks like patients had significant improvements in their aesthetics and overall patient satisfaction, which is probably relatively reflective of what they're looking for, you know, in addition to the function for these patients. So I think it's great that they were able to provide that data.
It's always good, as we've talked about many times on the podcast, the importance of having kind of the patient-reported outcomes of what patients actually care about. I mean, we can say that treatment is good or bad and, you know, degrees of improvement in contracture, but like we talk about, the patient outcomes are what matters to the patient and ultimately what we're trying to deliver. Raj, I'm wondering at WashU, what is your guys' mainstay for kind of Dupuytren's and then recurrent Dupuytren's treatment specifically? Are you doing collagenase? Are you doing limited fasciectomies versus aponeurotomies? What are you guys doing?
It's very similar to what Dr. Neumeister mentioned. You know, I think for most patients, and obviously I think our experience is less than this paper's experience, especially with the recurrent Dupuytren's, you know, over the same time period at least. Yeah, we do collagenase initially as a first step treatment for patients who just come through the clinic. And then, you know, for recurrence, We don't really do a whole lot of needle fasciotomies, so then we would go to a limited fasciectomy and then kind of go from there. So that's normally, for most patients, we'll start with collagenase and then build from there. There are patients who will opt for, just depending on what their preferences are and what they tell us, where we'll just go with a limited fasciectomy to start. But I would say it's much more common to do collagenase. And then, multiple recurrences, to be honest, I think that's a smaller subgroup of people, and then I think we kind of just treat those on a patient-by-patient basis. It's pretty similar to what's been mentioned already.
Dr. Neumeister, I'll give it back to you. I wanted you to comment lastly, just what do you think our listeners should know, the take-home from how they should use this article to counsel and educate the next Dupuytren patient that they're seeing in their clinic?
So what I would say is this is a good article to actually counsel the patients on, can they expect to have, one, a recurrence, and two, if they've had a lesser procedure. And I say that not meaning that, it's bad or anything, but a needle episiotomy is less invasive than the partial fasciectomy. But if they've had that lesser procedure, the chances of them coming back and needing an operation are higher than if they do the limited fasciectomy. But we should still be able to get you straight again if it were to recur, knowing that complication rate could be higher the second time you're in there, and that the natural history is really not known for any one individual.
Thank you, Dr. Neumeister. I appreciate the talk and the comments. I think that's really critical, is how we can deliver this article for what it does and how we can translate that to kind of the bedside when we're interacting with patients. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other two articles that we will be discussing on this month's podcast. Finally, please join us for our monthly Journal Club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly Journal Club takes place. And once again, thank you so much, Dr. Neumeister, for joining us.
Thank you so much. I've enjoyed being a part of this.
Thanks for listening to the award-winning PRS Journal Club podcast. Please click, subscribe, and leave a ratings or review if you're enjoying what we do every day.